गुड इवनिंग।
गुड इवनिंग बाबा सर, कैसे हैं?
आप ठीक है? बिल्कुल ठीक।
एकदम बढ़िया। डॉक्टर बाबा
ओके।
सीनियर इन एमसीएच।
नाइस नाइस नाइस
सीनियर
टू
है पर निसार सर के साथ मैंने काम नहीं किया, बाबा सर के साथ काम किया है।
नाइस नाइस टू हियर यू।
सेम ईयर सर।
ओके।
Good evening, sir. Good evening, Nisar sir.
गुड
Yeah,
इवनिंग।
good evening, good evening.
गुड इवनिंग डॉक्टर मुनीर।
Good evening.
Simran, are you there?
I think, sir, she is not there yet.
सिमरन
No, she must be trying again. She is also.
डॉक्टर सिमरन Shafi is there. She has started sharing
Yes,
us.
started speaking. Share.
Yes,
Yes.
yes, yes.
Yes.
She's there now.
Sir, we'll wait for 2-3 minutes, then we can start.
Yeah,
I
yeah. I think this is the
Dr.
first
Vikesh
time.
also, he said कि if it gets the time, he will also be there for
Who is that?
Vikesh Agarwal, sir. Our already
Okay.
sir.
विकेश सर तो कायरो में है ना, इजिप्ट में आ गए।
He said कि online वो link share कर दे।
ओके ओके ओके।
Simran? Simran, can somebody call her to, because maybe she has, her mic is still mute.
I will try to call her, sir.
Please.
डॉक्टर सिमरन, आपका माइक म्यूट नहीं है, बट वी कांट हियर यू। देयर इज सम प्रॉब्लम विद योर सेटअप।
You can join again. You can unshare and you join again.
ये
Dr.
माइक
Vijay, you can also mute her if you're the host. You can
Dr.
unmute her.
Sudhir है ना Dr. Simran.
Can you hear me now?
Yes.
Yeah,
Yeah.
yeah.
वेरी मच।
Simran, you can go ahead.
Yes, sir.
Should we start, sir?
Yeah.
Should we
Shamil,
start or
you
we
want?
should wait for some time, sir?
Just 2-3 minutes, sir. We'll wait for
Okay, okay. No issue. Okay. The moment you are ready, you just let us know. Okay.
डॉक्टर सिमरन, आप एमसीएच कर रहे हो या कर चुके हो?
Sir, I'm actually a senior resident yet. I haven't started my MCH. I mean, I haven't.
You joined your post MS senior resident.
Yes, sir. Yes.
Non-acad, yes, sir.
So you're planning to join pediatric surgery in the future?
Yes, sir. She is very
Yes, sir.
interested in pediatric surgery now after joining our department.
That's great.
We have around 15-16 members, sir.
Oh, that is okay, I think.
The first meeting, sir, it's acceptable.
It's a good set to start with.
Hello. Hello. हाँ जफर बॉस।
Dr. Munir has joined us.
Yes, sir. I've joined.
Oh,
Good evening.
Dr. Wo, he is here. Good evening. Assalamu alaikum. How are you? कैसे हैं? ठीक है?
I'm good, sir. I'm बढ़िया से बढ़िया। आप ठीक है?
कहाँ हो? चंडीगढ़ में आप?
हाँ जी सर, चंडीगढ़ में।
चंडीगढ़। So Dr. Zafar is traveling, so he may not be able to join. So with your permission, if you allow, we can start, sir.
Okay, sure.
So good evening, dear all our respected senior members, our moderators come chairpersons. We have 2 cases today, neonatal obstruction, unusual causes, and cryptomenalia beyond the imperforate hymen. Will be presented by 2 senior residents from Sher-e-Kashmir Institute of Medical Sciences. And our moderator for today will be Dr. Prabodh Goel, additional professor from AIMS Delhi. And another moderator is Dr. Munir Malik, additional professor from PGI Chandigarh. And these 2 cases will be presented by senior resident, and for backup support, Nisar sir and Dr. Rashid will be there. with this, I requested Dr. Vikesh also. He may also join our our meeting. We are happy. We are very thrilled that we are having, and in future also we'll try. We'll have at least 6 weekly or 8 weekly, once in a 8 weeks or 2 months, one meeting, online meeting, where we will have either case presentation or some interesting topics, whether from within the state or from outside also, if all agree. So with these words, I think with these words we can start. I'll request Dr. Simran Shafi to start. We can hand over to Dr. Munir and Dr. Prabodh, please.
हाँ जी,
इको हो रहा है किसी का।
आई थिंक दो डिवाइस
Dr.
साथ में
Vijay
हैं
का हो
आपके?
रहा है।
वो किसी ने किए होंगे ना, उनको लॉग इन और लॉग आउट करना पड़ेगा। किसी के भी 2 लॉग हैं तो मेरा तो एक ही है भाई।
किसी ने
Okay,
साथ में रखी हुई हैं।
I think because I had some issue in joining there. I was on the phone. Now I have connected my computer.
हाँ, निसार सर आपका ही।
सर एक ही करना पड़ेगा आपको सर।
Yeah, that I have just closed one.
ओके सर। ओके, डॉक्टर प्रभु, डॉक्टर मुनीर प्लीज।
हाँ जी,
Okay.
सो डॉक्टर सिमरन, आप करो प्रेजेंट। go more in a teaching mode, right? That's good for you.
Yes, sir. Yes, sir.
Please start.
So, yes, sir. Good evening, everyone. I'm Dr. Simran Shafi, Senior Resident in the Department of Pediatric Surgery from SKIMS, Srinagar. I would first like to thank all of you for allowing me the opportunity to talk a little bit on neonatal obstruction, wherein we'll be exploring an unusual cause. Yeah. So my case begins with a 10-day-old female baby who was born second in birth order via LSCS, and she presented to us with a 2-day history of bilious vomiting on and off, along with abdominal distension and constipation. So when we received the child, she was quite dehydrated. So we stabilized her, admitted her, put in an NG, wherein the NG aspirate was bile tinged. We initially performed a USG abdomen in order to rule out malrotation, wherein we found
Sorry, I'm
that.
interrupting you. हाँ, देखो, you told us a 10-day-old girl, second in birth
Yes.
order, born via LSCS.
Yes, sir.
एक जनरल आउटलाइन हो गया बच्चे के बारे में. You told us the presenting symptoms.
Yes, sir.
2 days history of bilious vomiting for 2 days.
Yes, sir.
2 दिन में bilious vomiting को आप on and off कैसे बोलोगे? I think it's better to say it's a bilious vomiting for 2 days.
Yes, sir.
On and off means कि कभी ठीक हो जाती है, कभी हो जाती है. So
So
2
it
दिन
was,
में
yes, sir.
no, so I think on and off के लिए the tenure has to be a little longer. Then
Yes, sir.
child has associated distension of abdomen and constipation.
Yes, sir.
ये आपके 3 presenting symptom हो गए.
Yes, sir.
Before going on to how and what you did, would you like to talk more about these symptoms?
Yes, sir. They said that according to the parents' history, whenever they used to feed the child, the child usually used to vomit out, which was greenish, yellowish to greenish in color. And it was not with every feed. It was like present with some feeds, and some feeds were tolerated at that time. But they said that the abdomen of the child has been distending, and the child wasn't passing stools since 2-3 days. Initially, there was no history of delayed passage of meconium, but after that, the child hasn't been passing stools properly. That is what the history was, sir.
So see, now the history of delayed passage of meconium would go into past history here, or it
Yes,
would
sir.
rather go into a negative history. But
Yes,
then
sir.
I'm stuck on these 3 complaints. The child presented with bilious vomiting. So see, I assume that the first vomiting would have been non-bilious.
Yes, sir.
Gradually it would have become bilious. So
Yes, sir.
चीजें आती हैं. Number 1 was the we have not mentioned if the child continued to accept normal feeding. क्योंकि अगर vomiting हो रही है, bilious हो रही है, abdominal distension हो रहा है, तो possibly there is a decrease in appetite also. The
Yes, sir.
child is not interested in feeding. Number 2, whenever we talk about vomiting, तो vomiting से पहले का phase, मतलब was the child uncomfortable prior to vomiting? Was the child immediately hungry after vomiting? No. What
Yes,
was
sir.
the volume of vomiting vis-a-vis the volume of feed? if you can actually give us the frequency, maybe 3 times on the first day and 5 times on the second day.
Yes, sir.
Then when you talk about vomiting, अभी मैं केवल vomiting की बात कर रहा हूँ, so that brings into my mind the associated symptoms. So आपने बताया it was associated with abdominal distension, which was progressive or not. Then
Yes.
when you have abdominal distension, are you seeing something on the abdomen? I'm talking of visible peristalsis.
Yes, sir.
Was the distension upper abdominal or it was a generalized distension? Sir, आप कुछ कह रहे हैं?
Yes, Dr. Provod, actually, we have to consider it just 10 days old only, okay?
Yes, sir.
So patient has been feeding well for first 8 days of the life. So just 2 days before the admission, I mean, day 8, patient started vomiting. Of course, these mothers are not so, literate that they can tell us those, all those things. But he had a vomiting. As Simran said, it was not every time, bilious. In between, it was bilious and non-bilious. But 3-4 times, both that, in 2 days time. And in fact, the first day he had a vomit, second day she got admitted with us.
Okay.
Okay. So then coming to the abdominal distension, it was a diffuse distension. It was not like visible because you don't expect in 10 days old. It was diffuse, distension, and there were no visible peristalsis. It was just like a distension.
Sir.
So then, yes, patient had associated constipation also these 2 days only. Okay.
So basically,
Then,
not passing stool for 2 days.
yeah, she was conscious for 2 days. Yes, definitely. Simran, can you go ahead now?
Yes,
Yes,
please.
sir.
And
So
was
we,
this child term, sir? Dr. Simran, it was
yes,
a
sir.
term child, normal birth weight, birth
Yes,
weight,
sir.
and
Yes, sir. Term
maturity,
child, sir. Yes, sir. Yes, sir. Normal birth weight, sir.
and good birth weight.
Yes, sir.
Go ahead, please.
Then the child was admitted. We stabilized the patient and we placed an nasogastric tube. The aspirate from the nasogastric tube was again bile tinged. So the initial investigations we did we performed a USG abdomen in order to rule out malrotation. That was our first thing that came into our mind. Wherein we found that the SMA-SMV axis was maintained. At the same time, we performed an X-ray abdomen of the child, wherein we saw that the X-ray showed distended gut loops. In order to look, sorry, sir.
Without air fluid levels, right?
We
We did
will
a
come with the
supine
X-rays.
film.
Can we
Supine.
go to the X-rays, Simran?
Yes, sir. Yes, sir. So
Yes,
this was
without
the
air
initial
fluid level.
X-ray which was done.
So there's a
And the
dilate
second,
bubble and there are no air fluid levels.
yes, sir. This was a supine film.
Okay.
There were just distended gut loops, and obviously on supine film we couldn't look for an air fluid level. And after that, we even went for a lower GI study to look for any distal cause of obstruction like Hirschsprung's. And after that, we even went for an upper GI study to look for any upper GI cause of obstruction, like if there is any duodenal epitheliary web or any cause of malrotation present on upper GI. And even after we did all these 3 studies, it came out to be unremarkable, and there were no causes which we could make it out on the X-rays. We put the child on conservative management, and the child actually she showed improvement over a period of 4 days. She moved bowels. We just gave a little bit of rectal stimulation. She moved bowels, started tolerating orals, and we discharged her home on breastfeeds. But then, unfortunately, the child came again after 7 days of discharge. The child was brought again with multiple episodes of post-feed bilious vomiting, and this time the frequency was increased. With every feed, she was vomiting as compared to the previous admission. And even the abdomen had become quite more distended than what we had seen in the previous admission. We again resuscitated the child, we re-evaluated, and X-ray abdomen was done. So this was the second admission. This was X-ray abdomen which we did in the second admission. Again, there are like the complete whole bowel is dilated in these X-rays. Since the child was having persistent bilious vomiting, we did not wait for long and we went for an exploratory laparotomy in this case. And the intra findings were that the whole gut was dilated, and we sort of had a region of disparity which was doubtful, occurring at the level of DJ. The large bowel also was dilated up to rectum. So small bowel as well as large bowel, both were dilated. We did a duodenotomy to rule out a web. which was absent because we had this doubtful transition thing. And at the same time, to confirm whether it is Hirschsprung's or not, we went for a rectal biopsy. Even post.
I'll stop you. Actually,
Yes, sir.
it was not a doubtful transition. There was definitely a transition. The duodenum part fourth was dilated,
Yes,
and
sir.
the jejunum was also dilated, but there was disparity of 2:4.
Yes,
So
sir.
keeping that thing in the mind, we thought probably there is a web or something. So that's the reason we had to do the duodenum. Okay, you please proceed.
Yes, sir. Even after the procedure, after the laparotomy, post-operatively, the child continued to have abdominal distension and bilious aspirate via NG tube, and the constipation also was persistent. We performed serial abdominal X-rays when she was while she was admitted, and that also showed persistently dilatation of the bowel. And meanwhile, we even received the rectal biopsy reports, which showed us the presence of ganglion cells in the intermuscular plexus. Now the question was, the child is continuously, she's having bilious vomiting, abdominal distension, constipation, she's not moving bowels, upper GI, lower GI studies are normal. Even on laparotomy, we couldn't have any such positive findings to label what was the actual cause of obstruction. That led to a diagnostic dilemma because we were not able to find any mechanical cause. So, can anyone among us can just throw some light? What could we do next in these patients? In this patient,
Okay, Simran, what was the status of bowel sounds?
sir, bowel sounds were almost sluggish to absent, sir, in this child.
So you see, there are three possible situations. Bowel sound can be normal, sluggish, or exaggerated.
Yes, sir.
Now, they are not exaggerated for sure, you told me, and you already said there is no mechanical cause. So if there is a mechanical cause, I expect the bowel sound to be exaggerated.
Yes,
And you
sir.
think they are sluggish, then that definitely points out towards an organic pathology. अब आपने लेप्रोटमी की फाइंडिंग के हिसाब से तो यू आर सेइंग देयर इज नथिंग इन द बाउल, एवरीथिंग इज फाइन. जो आपने
Yes, sir.
इनिशियली वेरियम मिनिमा दिखाया था उसमें रेक्टम उतना डायलेटेड नहीं है, राइट?
Yes, sir.
वाज इट मोर डायलेटेड इंट्राऑपरेटिवली?
Rectum was up to the rectum. The whole bowel was dilated, sir.
Okay. Did we try to do a complete variant meal follow through in this child? No.
ये वाला है सर इसका
ये वाला है इसका
upper GI contrast.
तो अगर हम ऊपर से देखते हैं थर्ड इमेज में आई कैन सी द स्टमक, फोर्थ इमेज में स्टमक के बाद एक्चुअल में सी लूप कौन सा है मुझे क्लैरिटी नहीं आ रही है. मतलब अब इसमें तो मैल रोटेशन पता चलेगा, बट डायलेटेशन ऑफ बावल इज लार्जली स्मॉल बावल एंड डेफिनेटली इट इन्वॉल्व जजेनम एंड मे बी अर्ली आइलियम. जो एक आपने प्लेन एक्सरे मुझे बाद वाला दिखाया था, तो इट डजंट लुक, हाँ ये वाला, तो सी इट लुक्स द नंबर ऑफ लूप्स टेल मी के इट कैन नॉट बी अ मैल रोटेशन. इट इज डेफिनेटली बियॉन्ड द स्मॉल एंड लार्ज बावल. सर कुछ ऐसा हो सकता है कि जिजनम में आइलियम में वेब हो, निसार सर?
No, actually, to be you see, when we have done already laparotomy, probably now this contrast will take a back seat, because now we know that there is no and I mean the whole bowel from duodenum to peritoneal reflection. I mean involving the large bowel also.
Is
It was
normal.
whole of it was dilated. As I told you, between the duodenum I mean fourth part and the jejunum, there was definitely disparity 2:4. That I thought of this, web. Probably I thought this is the reason, but then I explored. I did not find that web. So the dilatations, it was a uniform throughout. It was not something like at any place. See now, if we summarize this, that is just neonatal obstruction with the contrast steady normal. Laparotomy, we could not find anything to suggest the malrotation, and the whole bowel is distant. And post-operatively, in fact, for 10 days, see, we thought one of the possibility could have been something like paralytic ileus or hypokalemia. Those things probably were not, because patient there was no evidence of sepsis. Electrolytes are normal. Something bowel was not functioning. Okay. Bowel was not functioning. So that made us to think something like what we call a Sanva. You can go ahead now.
Yes, so the child didn't even deflate for 2 weeks, and we had almost ruled out all possibilities. So now the thing that came into our mind was like a very rare cause, which is known as pediatric intestinal pseudo obstruction. So before I go into how did we manage it, I will just like to tell the definition of it. Pediatric intestinal pseudo-obstruction is basically a disorder which is characterized by the inability of the GIT to propel its contents, and it mimics a mechanical obstruction in the absence of any lesion occluding the gut. If it's persisting from 2 months from birth, we can call it as a chronic intestinal pseudo obstruction, or even if it's up to 6 months after thereafter. But since it was very early and the child was very rich, we would just label it as a pediatric intestinal pseudo obstruction. Now, SPEGM has given us a criteria. Like until recently, we had no criteria to even diagnose this case. But SPEGM has now given us a criteria of 4 objectives, wherein if 2 objectives of these are satisfied, we can label it as a case of PIPO. So the 4 objectives, the first one is the inability to maintain an adequate nutrition or growth on oral feeding. Here again, our child was not able to maintain oral feeds because she was continuously vomiting. Second was recurrent or persistently dilated small intestinal loops. So again, our child also was fitting into the criteria. 2 criteria are already established. We could diagnose it as PIPO. The other 2 criteria are objective measures of small intestine involvement, wherein we can do a transit study or a manometry, as well as a histopathological diagnosis of small bowel presence of hypoganglionosis or inflammatory conditions. And the fourth one, if it is a known case of any genetic or metabolic disorder, which is usually associated with PIPO. So how do we actually go for management of patients who are on PIPO? Is first and the most important thing is the maintenance of nutrition, wherein it's important to preserve the growth and development. So we started our patient on a total parenteral nutrition. Again, the second most important thing for us is to limit the symptoms and increase the quality of life, as well as prevent complications of bacterial overgrowth and sepsis. So we initially started the child on upfront pyridostigmine and syrup erythromycin, but since she wasn't tolerating it orally, we had to escalate it to injectable neostigmine, which was done under monitoring in the ICU. Luckily, our child began to respond, and the NG aspirate quantity started dropping to almost nil in around 5 days. Then we started test feeds on her. She tolerated the feeds, and the child was then put back on breastfeeding. The child again started spontaneously moving bowel after this neostigmine administration, and sometimes we had to occasionally use a glycerin suppository. With time, the injection neostigmine was de-escalated, and we shifted her to oral pyridostigmine along with erythromycin. And by the grace of God, the child finally went home on half the dosage of the drugs and exclusive breastfeeds. Now, the important thing I wanted to mention in this case is that pediatric intestinal pseudo obstruction is actually a diagnosis of rarity, wherein we have a lack of clarity because we don't know the exact etiopathogenesis behind this condition. We didn't have until now a proper diagnostic criteria. Neither do we have a proper thing to classify this condition. Again, we also have a lack of uniformity because the available expertise is very less. There are no proper diagnostic protocols to say that this and this is the way we go for it. And there are not particular management strategies. More importantly, when we look at the literature, these patients usually come with delayed referrals and delayed diagnosis with repeated unnecessary abdominal surgeries. Like usually they go for 3 to 5 unnecessary surgeries before they are referred to a proper pediatric specialist. And they have poor feed tolerance leading to 100% dependence on parenteral nutrition with increased complications, morbidities, hospital stays, as well as poor quality of life. So finally, the take-home message would be that these cases, although it is very rare, should be one of the diagnosis of exclusion, wherein it would need a dedicated hospital-based multidisciplinary team, and it requires a thorough knowledge of whatever available tools we have, and so that we can utilize different strategies in order to diagnose as well as later on manage these patients. Thank you.
Thank you, Simran. Very well presented. I want to make 2, 3 small comments.
Yes, sir.
One thing is, if you request your histopathologist to look into the biopsy again,
Yes,
he
sir.
might find some evidences of either neuropathy or myopathy.
Yes,
Yes,
sir.
sir.
अभी
Yes.
क्या है, जब आपने पहली बार बायोप्सी भेजा होगा, you might have sent with the mindset of Hirschsprung disease.
Yes,
But
sir.
now that you have diagnosed intestinal pseudo obstruction, and the treatment of that is also giving you results.
Yes,
So
sir.
you do those biopsies again.
Yes, sir.
Thing है कि now this was from the perspective of this disease. Now my next 2 points pertain to the perspective of case presentation as a resident.
Yes.
So suppose we don't know the diagnosis and we are still looking into surgical causes. So we should talk about the thyroid status in such
Yes,
cases.
sir. Yes,
And
sir. Yes.
other is we should talk about ultra short Hirschsprungs.
Yes, sir.
So बाकी
So the
rest
thyroid tests were done, sir. The thyroid profile was completely normal in this patient.
watch है तो that is one thing we should have come up. और generally ultra short Hirschsprung ऐसा category होता है जिसमें biopsy normal आती है but still it can present like this.
So probably, Dr. Prabodh, probably that we can exclude if you see the patient's overall the PURA findings, and I think that can be simply excluded in the sense that see if the patient is dilated, this short segment, whatever it is, I mean a classical or a short segment, patient's presentation has to be different. I mean,
Yes.
initially it has to be for
नहीं,
some
I
kind of
agree with sir.
cornerstone,
अब तो
but
सर
the
अभी तो exclude हो ही गया वो मैंने as a resident case
no,
present
okay, yeah. The point is always there. Yes, we well taken. In fact, see, about before this, we had a one patient we sent into, I think, doctor, he was under the care of Gawar Mukti. I don't know whether he has joined us or not. He is in conference somewhere, Udaipur. That patient, we sent it for the biopsy. This is exactly what you were saying, some neuropathy, that report we got it, okay? In fact, just I want to add that we have almost, I don't remember, is it 7 or 8 patients we have already seen it. Okay, their typical presentation, they come in the obstruction. Within 2-3 days, these patients, they deflate, put on the feeding, they tolerate, come back after maybe 1-2 months. Again, of course, we evaluate them for everything. So it is actually the by exclusion criteria and frequent obstruction without any cause. Okay. In fact, I will tell you about the one patient. Once we diagnosed him like this, then second, third, fourth time he went to one private practitioner in the Srinagar. He did the colostomy, he did the laparotomy. He could not find anything, so he went for the colostomy. Okay,
Yes, sir.
but unfortunately, that colostomy did not function for another 10 days. So people went to Delhi. They said probably he has not done it properly, so they revised him this colostomy.
Okay.
Now the patient remained for 3 months. The colostomy did not function. Unfortunately, patient had gone to the private hospital. Then he involved our government. Then many people got involved. We had to shift to that patient because he could not afford that private treatment. Somehow, with the time, we could close that stoma. Now patient is in a regular follow-up with in between getting to these episodes of obstruction, but maintaining weight, everything. I have another patient, the same, who had a history like frequent.
Sir, biopsy in that patient was normal, which you are mentioning,
With this patient,
with that twice colostomy revision and all that.
no, I have no idea about class whether they had done it. See, actually, everything was why this patient is not functioning. It is 2 months is a big 2 to 3 months is a big time. Okay. In fact, what Simran said, it is the chronic pseudo-obstruction, what we can label that patient. We have one more patient. I'll tell you, Dr. Vijay, with the same thing. Okay. He's from Rajouri. I had just given them one word of advice. Please don't allow anybody to operate on your child. Okay. But from Rajouri, I think it was something like winter, this road was closed. They went to Jammu. I don't know. Somebody has done the laparotomy and did the colostomy. Then after some months, patient reported back to us because we closed this colostomy and he's again on the follow-up. So same way, we have other 4 or 5 patients who had this sort of pseudo obstruction, but we could not find out the cause.
So it's only for those cases which do not present classically as a Hirschsprung disease, or there is no clear-cut diagnosis. Only in
those things. See, actually, what she said is a rare entity, and by it is. In fact, I'll tell you one patient I operate. If you see, sometimes whole bowel may not be dilated. This is segmental dilation. Part of it is dilated, another part is collapsed. I have seen some patient laparotomy. This is what I could find there. Okay, so actually, before we label them, we make sure that patient does not have any other, including no other reason for this obstruction. Okay, that is how we diagnose them.
So that means whatever we have discussed now, this pseudo obstruction is a diagnosis of exclusion only. After we rule out all other organic or functional lesions, then only we can make a diagnosis of this
But
case.
the Simran shared the inclusion criteria also. How we diagnose those?
तो डॉक्टर निसार, अब मैं ऑनेस्टली बता रहा हूँ, अगर ये केस मेरे पास आया होता तो वी वुड नॉट हैव डायग्नोज्ड सूडो ऑब्स्ट्रक्शन सो अर्ली, बिकॉज वी आई डोंट रिमेम्बर सीइंग अ केस इन द पास्ट 15 years. सो आपके पास अगर 3-4 केस आए हैं तो
We have 7 cases.
7 cases. So, sir, I want to give you 2 suggestions.
Uh-huh.
One thing is a detailed history if there is a local practice of feeding the child something which may be causing this, some dietary pattern or something.
Yeah,
No, that is not okay.
And second thing is we can actually do a whole exome sequencing study in these 7 patients. There might be some genetic predisposition.
Yeah, of course, they have this pathology. Yes,
So
definitely.
if their patients are following up with you, actually I am doing a lot of whole exome sequencing in my patients of congenital malformation these days.
Okay.
I'll tell you one interesting finding. जैसे अभी एक इस बार JIAPS में पेपर छपा है स्पाइना बाइफिडा के ऊपर. So there is a internationally acknowledged spina bifida gene panel which is around 42 or 43 genes. मुझे exact number नहीं याद है, something in this range. तो हमारे पास 3 पेशेंट आए, हमने उसका होल एक्सोम सीक्वेंसिंग किया टू लुक फॉर द जीन्स विच आर देयर इन दीज चिल्ड्रन. हमें उस जीन पैनल का हार्डली 1 या 2 जीन मिला. But we found 4 genes which are common to all the 3 patients. All 4 genes have been described something in neuropathy, but none of them has been described in spina bifida. So same thing in extrophy, same thing in Wilms tumor, and same thing in hepatoblastoma. Hepatoblastoma मैंने अभी एप्सोकॉन में प्रेजेंट किया था.
Yes, that's very interesting.
हाँ, तो what is happening is हमारे जीन्स जो हैं वो थोड़े से डिफरेंट हैं वेस्टर्न वर्ल्ड से. अल्टीमेटली कॉमन चीज क्या है कि दे आर वर्किंग ऑन द सेम मॉलिक्यूलर पाथ पे, डिजीज सेम हो रही है, लेकिन एक्चुअल म्यूटेशंस आर डिफरेंट. अगर ये 7 पेशेंट आपके पास हैं एंड इफ यू फील इंटरेस्टेड वी कैन डू अ होल एक्सोम सीक्वेंसिंग एंड सी व्हाट इज द रीजन.
Sure, we can do that.
एनएसजी की अवेलेबिलिटी का भी है ना इशू. आई डोंट थिंक कि जेएनके में अभी है.
No, we don't have. We don't
मेरा जो
have.
डेटा जनरेशन होता है डॉक्टर कुंडल, वो होता है रेडक्लिफ लैब से. आई एम श्योर रेडक्लिफ की ब्रांच जरूर होगी जेएनके में.
ओके.
I think we can. That's a very good suggestion. And to be honest, I am convinced that I have not missed any, organic cause in this patient, including the Hirschsprungus. And remains the question of, problem with the feeding. Usually these patients, this is very unlikely, with the feeding. They have different presentation and whole bowel, actually it is sort of, they go in the transit, this motionless bowel. This is actually the condition what our patient also had the same thing. Of course, you have to exclude the other things, hypokalemia and paralytic illness, other things. But anyway, we can still, I mean, that's the reason we have put this patient for the discussion.
Sir, I would like to say one thing. Because short segment Hirschsprung disease is a disease by which we diagnose by manometry only. So I think that we have missed. I think the rest of things we have already done.
Dr. Ajaz, do you expect a patient of short segment to have whole bowel dilated?
Yes, because it's because the disease in the distal. I think Dr. Prabhuth he suggested that short segment, which is I think it should be in the mind of.
No.
Because
my question is just for the discussion because residents are there. Should you ever consider even any Hirschsprung's disease in the day 10 of life? Whole bowel is from stomach to the rectal reflection, it's all dilated. Naturally, whether it's a short segment or a classical Hirschsprung's, the obstruction has to be started from below upwards.
Obviously, when there is a distal obstruction, the proximal will
exactly. So it takes time. It does not happen in 2 days time, everything. Yes, of course, that point is there.
But as a part of the workup, we should include manometry into
of course,
before
labeling. Of course, we must.
So we'll take comments from Dr. Munir also.
This is just for students. That's all.
Dr. Munir, please.
Yes. So, as far as I understand, there was a dilation till peritoneal reflection. If there is any etiology, it has to be below that only. So, I think one possibility of short segment Hirschsprung is still there, but sir has already done a rectal biopsy. More or less, it's ruled out. It's done from proper side. So, second is intestinal neural dysplasia also. So we go to the pathologist and tell him that what are the type of ganglion cells they're seeing, how much nucleated they are. give us, if you can do further stainings, that will help in solving the problems. The IND type 1A, they behave like that only. You just need to give some laxative, some water, and they just overgrow. They outcome, they just, outgrow this problem. Second is enteropathies. So for that, you need genetic workup. You need genomic sequencing. I also had a patient similar presentation where it was positive for ACT2 genes for microcystic microcolon, megacolon. Sorry, megacystic microcolon.
Megacystic microcolon, sir.
Yeah.
I remember exactly.
Yes,
I was
yes,
thinking of
yes,
that.
yes. So that patient also behaved like this. All ganglion cells were present everywhere. Complete biopsy, everything done. So these are two possibilities. I don't think there is any upper obstruction here. Uh, this was always dilated till pattern in all the X-rays in upper GI contrast. So this was a lower GI obstruction. So sir has nicely managed it. Appreciations for complete and excellent management for this case. I think the genetic workup requires to be done.
Okay, thank you very much. I think well taken.
Yes, sir. We can now move to, I think, second case if Dr. Prabhuda also agrees.
Yes, please.
Dr. Narendra Singh sir has also joined. So welcome, sir. Now, I think second one is our Dr.
Dr.
Narendra
Narendra
Singh.
Singh, welcome. Good evening.
Narendra sir, welcome. Good evening, sir.
Sir, unmute yourself, please.
सर अनम्यूट करिए अनम्यूट हाँ
Unmute.
सर आप म्यूटेड हैं सर म्यूटेड है अभी भी द मेन टाइम डॉक्टर Sabrina.
Sabina, Dr. Sabina.
I am making you co-host so that you can start sharing.
Yes, sir.
Sir, good evening.
Good evening.
Dr. Narendra, good evening. Welcome.
Welcome. Good evening to everybody.
Dr. Narendra, good evening.
Sir, thank you, sir.
Good
आप
evening.
busy थे आपने time निकाला. Thank you.
Yes. I thought
Good
I
evening.
should join whatever time I go.
We have 19 members now. 19 members for state. I think it's a good number.
Very nice.
Are you able to share, Dr. Sabina?
Fahim, can
Just
you?
a second, sir.
Okay.
No problem, please.
I think she is working on it. Till she shares her this screen. The reason for this presenting this case was that this cryptomania, these patients they move from pillar to post, and from gynecologist to the general surgeon to plastic surgeons to the pediatric surgeon. It is although very rare, to find the cryptomania beyond like this imperfect hymen, like cervical atresia, vaginal atresia, and other things. So since pediatric surgeons are well versed with these congenital anomalies, so we have seen till now we have 4 patients which are operated on with this issue, and because this patient is in fact one of the patient who was diagnosed at 27 years of age. Imagine 14 years she has been, carrying this problem. So I thought, why not, share these cases with you so that in future we are, aware about this area anomaly. Dr. Sabina, are you ready?
Sir, yes, sir, I'm trying to share it. I don't know what has happened to this.
I think you are now.
Yes. Kindly keep
Yes, I think.
slideshow mode.
Shall I go to the slideshow?
Just a second, sir.
Yes.
Is it done, sir?
Yeah,
No.
yeah. You're okay. You can see it.
Full screen and slideshow.
Is it fine, sir?
Yeah.
Good evening, everyone. I'm Dr. Sabina from Department of Pediatric Surgery, and I'm doing MCH. I'm first year MCH in Skim Sora. So I'm going to present cryptomania.
Full screen नहीं हुआ.
डॉक्टर सबीना, आप इसको स्लाइड शो मोड में ला सकते हो, ये नीचे, हाँ, ये जो नहीं, लेफ्ट साइड में इसके.
Okay, sir. Done, sir?
Okay,
Yes.
yeah.
Sir, as we all know, it's an abnormal condition in which the products of menstruation are retained within the vagina because of an imperforate hymen, or within the uterus because of an occlusion of the cervical canal or vaginal agenesis. This is the image. Here we can see hematometra and hematocolpus. This condition is very often missed and often associated with diagnostic dilemma. These patients are associated with huge morbidity. The patient's functional, reproductive, psychological issues must be carefully evaluated and addressed. Coming to our cases, coming to the first case, this is the case of 12-year-old female child that started with severe lower abdominal pain on 30th November 2023. For these complaints, she visited GMC in view of non-resolving lower abdominal pain, where USG was done that showed echogenic dependent contents in uterus and cervix, showing hematometra with hematocolpus. Then this patient was referred to Gynae Hospital on 1st December 23 and was planned for drainage, but due to some reason, patient left that place. Then the patient was diagnosed as imperforate hymen, aspiration of 5 cc's of hematometra on 1st December was done at private hospital by general surgeon, and intraoperative findings were found hymen completely closed. Again started with cyclical abdominal pain. Incision drainage of hematocolpus was done on 1st January 23 and at private hospital, where CCT was done that showed hematometra, posterior fornix containing 30 findings. Previous hymenectomy didn't show any tract, a tough hymen high up, not approachable. Few tough parts of hymen were cut. Vagina was approached with difficulty by needle. Collected blood was drained. Then this patient again started with cyclical lower abdominal pain, and patient was planned for incision and drainage at private hospital, but patient refused because of lot of mental and physical trauma. Patient went to Gynae Hospital with same complaints. Their USG was done that showed hematocolpus, imperforate, queries of imperforate hymen with distended cervical canal with collection of 40 cc was done. Patient was referred to GMC plastic surgery, where from she was again referred to pediatric surgery, GMC on 11th March 24.
GMC, by the way, maybe this is a government medical college in Srinagar.
Then operation was done where examination and anesthesia was done with perineal exploration on 13th March. Intraoperative findings were distal vaginal pit present, proximal vagina not appreciated, iatrogenic posterior bladder wall injury was that time done, that was primarily closed. The patient was discharged on 15th March.
So just Sabina, let us stop it for a second. Actually, Dr. Munir and Dr. Prabhu, this patient had, 6 admissions in 3 months from different places. We thought she has been already admitted in our, LD hospital. That is our, gynae and obstetric hospital in Srinagar. I mean, in 2 different departments, then plastic surgery, then, and pediatric surgery. then we came to the conclusion probably these people did not think beyond the imperforate hymen. So we thought that we must present. That was the reason presenting this case here. And let me tell you, this patient is already post-traumatic psychosis, okay? Because every time wherever she went, every person was doing the local examination, giving pricks here and there. In fact, finally she had a posterior bladder wall injury. Sabina, you can go ahead, please.
Yes, sir. Then patient was discharged on catheter for 3 weeks. And later on, she had followed the OPT there, and it was found that she was having, on operative findings, she was having a gauze left over 6 centimeter was left in situ, and that was removed. She was having foul discharge at that time. Then the MRI was done that showed well-defined collection 3.5 to 3.3 centimeters.
By the way, Sabina, this urethral injury, no, I mean bladder injury, left of gauze, it was not, it was in the GMC, Medical College, Srinagar, okay?
Yes.
Okay.
Then MRI was done that showed well-defined collection 3.5 into 3.3 centimeters seen involving the upper vaginal canal on T1 homogeneously hyperintense and T2 hypointense. Distal vaginal canal collapsed, measuring 4.3 centimeter. Endometrial cavity not distended. Endometrial thickness was 5.6 mm. Possibility of vaginal septum, vaginal stenosis was made that time. Then patient was planned there for diagnostic lab with ureterostomy and vaginoplasty was made that time plan, but she didn't follow the advice. Then patient reported to us with similar complaints. And she had MRI done at private that was showing uterus dextro-rotated. Endometrial cavity is filled with blood. Tubular structure in left adnexa with maximum diameter of 25 mm. Mild hyperintense free fluid in pelvis. Mild hemoperitoneum. Impression of hematometra and left hematosalpinx was made. MRI was repeated in skims that showed distended uterus. Size was 7.5 into 4 into 5 centimeter. Distended cervix, left hematosalpinx. Impression of vaginal atresia, vaginal stenosis, vaginal septum or imperforate hymen was made that time. And then a patient with us underwent surgery, and we did end-to-end anastomosis. Vaginal anastomosis was done with drainage of hematometra, hematocolpus, and left hematosalpinx. Intraoperative findings were lower one-third of vagina was present, middle segment was atretic, hematometrocolpus was present, and left hematosalpinx. This is the short video that we had, operative video. This we can see. Here we can see.
A patient is already in.
Here we can see the vaginal plate is small, very 1.5 centimeters. Then we did the laparotomy. That time we are seeing this left hematosalpinx is there. This is filled with blood, and then I'm comfortable. This is the uterus. This bladder hitch we have done, and then we will see this uterus is filled with blood, completely filled with blood, it's inflamed, and then we have done this uterovaginal. This has been incised. Vesicovaginal pouch has been incised here. Then we are taking the stay sutures over the lower part of vagina.
See, actually, this is a very important step. Dr. Sabina, just hold on, because this is a very important step that, we're
incising this lower part of vagina, and we'll see this dilator coming out.
Sabina, just hold on. You just actually, opening this pouch is a, I mean, in view of the rectum lying just near to the vagina, because this patient initially had a bladder injury. So we made sure that we go through the pouch. We made our assistant to put the one finger in the, dilator through this vaginal pouch and finger in the rectum, so that to make sure that rectum is safeguarded. Okay. So after opening the lower pouch, we just, we have taken some stitch sutures. So this is the lower end of the vagina, which was the, blind. And just move. Okay, now you can see the lower end of the vagina. I mean this thing. No. You go back to this. Go back. You don't go to the. Yes, you can see once we have taken the that blind end of the vagina, we have just given the incision. This is the blood which is coming out of the this vagina. Okay. So then we did the anastomosis of the two ends of the vagina, bypassing that atretic segment. This is how we have complete our anastomosis. Initially the posterior, then the anterior layer. There were some few additional sutures to make sure that we don't leave the mucosa behind. There was some mucosa retract at few places. So this is the final picture. So from the below, we have established the anastomosis, vaginal anastomosis. We can go ahead, Sabina.
Yes, sir. This completes our one case of this vaginal anastomosis. Then we have the another case of 16-year-old female with cyclical lower abdominal pain for 4 years, and this patient was operated by gynae at a private hospital, with the construction of vagina was done without establishing continuity with upper part of vagina. And this patient was evaluated in skims, and MRI was done that showed segmental vaginal agenesis. Patient got operated in pediatric surgery department. Resection of atretic vaginal segment was done that time with primary anastomosis. Then we have the another case of 27-year-old female that was having history of again cyclical lower abdominal pain, and this patient was evaluated at gynae hospital, and this patient was operated there only. Initially hysteroscopy was showing no anomaly, and this patient was explored at this trust hospital and was found to have cervical atresia, and this case had remained undiagnosed for almost 13 years, and she was again having recurrent abdominal pains, and at the age of 27 years she got operated and uterovaginal anastomosis was done that time.
And this lady is a teacher by the profession, and she is happily married. Okay.
Yes, sir.
Then we have another fourth case which I have operated. This patient was she's a nursing student, 18 years of age. She came with the cryptomania, went to our gynae section. They asked our lab surgeon to do the diagnostic lab, and they confirmed that this patient has a cervical atresia. They want to take a help from our plastic surgery colleagues. Professor Ina was there. Somehow he knew that I have already operated this patient before. So he said, because you are well versed with these congenital anomalies, so I had to take over. So these are 4 patients of cryptomenorrhea. The reason for presenting this is, though is a rare, but it is really associated with the, huge morbidity. Dr. Munir and Dr. Probe, I will tell you, the lady who is the 27 years of age, who is already now married now. This patient told me that every month she would get admitted for minimum 5 to 7 days in the hospital, and during this period she would tie down her hair with the fan to overcome the perineal pain. This used to be that was the reason. In fact, I thought we must present share with you these rare cases. So the case is open for discussion. Please go ahead.
Dr. Munir, you want to start?
Yeah. First of all, it's a very good collection of rare cases. So vaginal atresia is not very common also. It's rare only. But sad to see that the patients do not come to us in time. The patients suffered a lot. But I'm sure there are findings in history which is missed by in the initial years of life. Usually they have urinary problems early on in the life. Somebody has missed those problems, not taken cognizance. So any of these patients having any renal anomaly, normally what we see is they usually have some renal anomaly, usually associated with ovarian syndrome, and then hemivagina is obstructed, not the full. But vaginal atresia is also not, I mean, we also see quite often, but it's not that common also. So, as far as rightly said, one has to be really aware about the situation. One has to think beyond vaginal, this imperforate hymen. And for the resident, I think she should have shown us what is the classification of this vaginal. Where do these cases fall in this classification? There's a classification for vaginal atresia, all four cases. Dr. Savina, you have an idea?
Dr. Sabina?
Dr. Savina, are you there?
Yes, sir.
Have you
Yes,
read
sir,
any
I'm here.
literature about it? Yeah.
See,
Yes,
How do
sir.
you classify them?
Sir, vaginal agenesis, this is, sir, yeah, we can classify it on the basis of, we have various syndromes associated with it. We have, sir, MRKH syndrome associated with it. It could be, there could be the underdevelopment of the vagina and uterus with normal ovaries and external genitalia could be there. Or we can have the MURCS association with it. They can have associated renal anomalies, skeletal anomalies, cardiac anomalies, or auditory anomalies can be there. Or we can have, sir, complete androgen insensitivity syndromes. They can also have vaginal agenesis. They have the vagina is either absent or it could be shallow in them. Or we have another syndromes associated with it, like hand, foot, genital syndromes associated. Or we have the
Yeah.
Frazier
So these are
syndrome.
syndromes basically.
Yes, we have
So there is
isolated
a
vaginal.
standard classification based on the. There is another classification based on where the defect lies: uterus involved, cervix
Sir,
involved, vagina, UVS
sir, it could.
classification.
Um,
Okay, that's okay. So that's fine. You presented well. That's okay. So, any experience with vaginal stenosis with these patients? Because I've seen few patients, they require dilatation quite
See,
often.
Dr. Munir, actually, this is the group of patients who are cryptomania beyond imperforate. Okay. We are not included the cases where we frequently find, like, this thing, common cloaca, and the other thing is where we need to do the vaginal replacement. That group is not actually included in this. That's a separate thing. This is exclusively who present with the cryptomania. Okay. So that means after the adolescent age, these patients present. But we have this group of patients, we could not find anything like, genital urinary anomalies. We could not find it there. Maybe we can, I don't exactly, to be honest, remember exactly was there. But as such, I did not, I don't remember anything extra in the other than this case. Because these
And do
patients
you
are,
routinely
I tell you
dilate
why.
this
I tell you why. These patients had ultrasound, they have CT scan, they have MRI, they have. So we had all those investigations. Probably some of this investigation must have picked up if there was a assisted anomaly. That's my point.
That may not be there. You have investigated all your patients.
Yeah, of course.
So, do you do, sir, a routine vaginal dilatation, this circular anastomosis
Yes,
different
definitely.
to
See,
stricture?
I tell you, I remember that because she was already a teacher and by profession at 27 years of age. So I have dilated her under the anesthesia. Okay. It was a normal caliber vagina. Okay. In fact, that patient had no issue with the vagina. She had a good size vagina. She had a cervical atresia. In fact, that uterus had become a shrunken. It was only few centimeters. It was the size of a walnut, a little bit more than that. So actually, I had very difficulty in anastomizing vagina to that uterus. Okay, so in that patient, probably there was no issue of this vaginal stenosis. But yes, this patient, the which we have done, I mean, just recently, after I think 3 weeks, I have again taken her under anesthesia, and I was very much happy with the that anastomosis, and there is no stenosis. I have done, I think, 22 or 20 something like that. I mean that is I mean adequate size. I could dilate with that patient. The other two patients, of course, from time to time we assess them, but by maybe by beyond 6 months or 1 year, probably, but they did not report back, to be honest.
And sir, do you ever consider putting a pigtail sometimes, like if there's repeated episodes of hematometrocolpus, just to decompress it and then do a dye study and see what is the anatomy up there? Or you
See,
directly
question,
go for surgery?
no, question is this again, you are gaining some time, but when you know the what to do, what is the ultimate treatment, why not to go? Because see, I tell you one thing. This time, doing anastomosis is a little easier. Then it when it shrunk is
Yeah.
down and probably get some
Yes, yes.
more fibrous. That is my point. But
Yes,
I
sir.
found
It
it
has the
easier to do
advantage.
this
Yeah.
time
Yes,
rather
sir.
than putting a pigtail.
So everything is dilated and it gives you extra length to do the anastomosis.
Exactly. That's my
Yes,
point.
sir. So that's the advantage. I think that's the point I wanted to make. Sometimes it's wiser to skip that pigtail thing.
Exactly.
It's not always required. Yeah. Thank you, sir. That's all. Thank you.
Nisar sir, ये perfect case है which highlights the importance of a pediatrics. Because any other specialty person would actually think of imperforate hymen as the first diagnosis.
Yes.
Now that a resident is presenting it, I would like to highlight whenever you will actually find imperforate hymen, it will show you the blood behind it. So bluish
Exactly.
that hymen will be bulging out. If you try to press it with your finger, it will be a boggy swelling. And more often than not, उस hymen को देखने के लिए labia को retract नहीं करना पड़ेगा. It is visible on the outside.
Exactly. It prolapses beyond this opening. Yes, you're correct.
This is where people go wrong and miss the diagnosis.
Yes.
Dr. Savina, if you note down these 4 points and go back home with this, so the purpose of
Yes,
presentation
sir.
is for you is served.
Yes, sir.
Sir, very nice collection. आपका
Thank you very much.
In fact, you should consider writing this series in JIAPS.
Hopefully so.
हाँ जी.
Narinder sir, any comments? Sir?
Yeah, I have only the experience of the neonates, but it is a very good collection. And I think the proper referral of these patients to the pediatric surgery department, we have asked our surgical colleagues, even if there is some congenital problem in the adults, they should refer to us, even if the patient is more than 18 years. So that should be the message of the that all the congenital problems where they are suspected, they should be referred to the pediatric surgeon. They are more experienced in that. Anyway, it is a very nice collection.
Thank you very much.
So,
So that is it. Anybody else? Dr. Ejaz, would you like to comment? Somebody who else is there?
Salim is there. Dr. Ejaz.
Yeah, I think it was a very nice collection. We have seen Professor Nisar doing these cases exclusively. We're very happy with our results. And it was nice to have this meeting, the first meeting of this class. Like
Riaz, Dr. Riaz is there. Dr. Riaz is there. Dr. Riaz is there from.
Good evening, everybody. Yeah, sir. I'm here. So,
Dr. Riaz, this patient, can you put some light on this patient, first patient who had just.
I was wondering, is it our case or not? Because I don't remember it.
See, actually, to be honest, although Dr. Niridhan rightly said that pediatric surgeons are well versed with congenital anomalies.
I remember one case, sir.
Then I thought probably, see, my point was simply that, the urethra, vagina, and they are in a close proximity, and the rectum. You have to make sure you cannot just, start doing fiddling without having proper investigation and proper anesthesia. Okay.
I remember one case, similar case, which we had done. I remember that having seen, I was not the part of the surgical team, but I happened to see that patient in the ward. That was a case wherein that patient was referred from gynae department, and that child had some neurosis, psychological disorder.
It's the same patient post.
Yeah. So if it is that patient, I remember I was not part of the surgical team, but I have seen that patient in the post-operative period, and we were not saying the diagnosis. There was vaginal atresia only, and we had done vaginoplasty. Is it if it is the same patient?
No. See, I tackle one thing, Dr. Yaz.
Because
Actually,
MRI was already done in that case by the gynae people. MRI was already done, and that patient was labeled as vaginal atresia because lower one third of vagina was cut, and the third how sir has done that, because seen none. Sir has done the anastomosis between the lower third and the upper part. But that lady was discharged. She was all well, and they followed up once with a similar swelling. We did dilatation and general anesthesia. That's all what I remember about that case. If it is the same case,
see, but when was it done? How many months before? Was it this year or
I
last
think
year?
I think last year.
Okay, maybe that's a different patient. But this patient, I tell you, when we took this patient for the, to the theater, she slapped our SR, and she said, why are you doing it? Then she got a psychiatrist, and she had actually post-traumatic psychosis.
Yeah.
We had to put the patient on the treatment.
We also sought psychiatric consultation at multiple times.
But
Not only of the
why
patient,
was this?
but
Why
her
was
mother
this
was
patient?
also having some psychosis. Yeah.
Dr. Riaz, my point is, why was this patient explode locally? Okay, when they had some bladder injury, what was the reason?
No, we have not explored. We have done that anastomosis in general anesthesia only.
Okay.
Second time, maybe while they were doing dilatation, and maybe there was some ooze, they might have put a pack in the vagina, and that patient, I remember, maybe if it is the same patient,
Yeah,
that
because
patient ran away
maybe
from the hospital.
what Sabina said, this patient had a gauze which are already full. But I will tell you, when I did the laparotomy, I could not find anything like it was all the virgin. Once I removed the,
Sir, where was the gauze? Actually, I am very curious because we operated first, then that patient, we dilated that patient. If it was in the vagina, because that patient had run away from the hospital, if I am right.
Anyway, that's
Sir,
not the issue.
we will focus on the topic only, sir. We'll not.
Yeah,
Okay.
it's,
That's not an
it's
issue.
really interesting to see the incidence of vaginal atresia skips in similar
But
region.
yeah, I must admit, it's we have little experience. I only remember this patient of vaginal atresia. I have not seen many, but yours is a large series. I think 4 cases you have highlighted. It's a very interesting and very it has added our knowledge, and yeah, the management also. Yeah, thank you, sir, for that.
Anybody else wants to comment?
Sir, may I
Any
add? Salim
feedback
here,
of
sir.
this patient, sir? Please give us the feedback of this patient. I am very interested in that patient because I remember second time he had that anastomotic narrowing, and we were doing dilatation. That's it.
Okay, we'll see that. With that, we can do it at our own level. No problem.
Dr. Salim.
Sir, I just wanted to put. First of all, sir, I would just congratulate the team for this first chapter. So very well organized, which is sir, and such a good audience here. So I just wanted to add one thing that like we are all saying that we should this case the congenital anomalies should go to a pediatric surgeon. Very well taken, sir. Very well taken. But the thing is, are we allowed to take these congenital anomalies beyond the age which has been, I would say, restricted to any institute, be it GMC, AIMS, PGI, or SKIM? So, like, we have a cutoff of 16 or 18 years. PGI has 12 to 13 years. Would we be allowed to take them? If we are, the main focus is on that we will be best to do that. But
Yeah.
are we allowed to do that?
I think Dr. Prabodh is here. I remember a patient who was already married, who had a kid, who was diagnosed Hirschsprung's disease, and she was done in pediatric surgery. Gupta ji operated on that patient. See, it is not the age does not come here. It is not. It is actually the condition. See, you are well versed with the condition. Okay. Same is true like many pediatric, this thing procedures where adult urologists, and it has happened number of times at AIMS. Urology people would call our consultants for doing their cases.
Yes, agree.
I mean, that should not be the criteria.
In my previous institution in Delhi, RML Hospital, we had one female, marriage age. She was, I think, 26 or 27-year-old, anteriorly placed anus with chronic constipation. She reported to us. So gynae people referred that patient. We asked the plan. We asked that patient he will have to undergo colostomy and all. The patient was not willing, but that was referred to us. So they send us.
One comment, please. Hello.
Yes, please go ahead.
Hi, Dr. Salim. We had operated during the last 2 to 3 months. The adult patient, all of them
Definitely,
had
yes.
done the.
Yes, that's I
They
know. I
all
know
of
that, sir.
them were the graduates with the anovestibular fistula.
Exactly, sir. Exactly. I accept that. The only thing what
We operated during the last 2-3 months. Both
we
of them
did
were
that.
adults.
Yeah, sir. What I want to say that then why do we have a specific like a number like 18 or 17 in different institutes? Why not to make it that a congenital anomaly, all congenital anomalies to be referred to pediatric surgery? Be it
That
ADH.
is just to avoid the rush. You have a cutoff. Otherwise, all the patients will come to the pediatric OPD. Specifically, if more than 18 years, I think they should come to the pediatric surgery.
Definitely, sir. I agree with
I
that.
think
Definitely.
I think this cutoff is for congenital, not for congenital anomalies. It is
It's
for
for
general pediatric surgery.
exactly.
Suppose you have
Yes.
appendicitis, trauma, you can say no after 13, 18, whatever you decide. For congenital anomalies, wherever the word is associated with congenital anomaly, you are fully entitled to operate on that.
Dr. Munir, at our times in PGI, Dr. Mitra was doing all the shunts, even if the patient
Yeah,
was 30
still
years,
going on.
35 years, above that age. He was doing the shunts and these urinary diversions also, Mitrofanov and all procedures in adults, because he is an expert in that.
So,
So
Dr.
even
आप सही बोल रहे हो.
Mitra was doing that.
I just want to add one point here. So, like in my department, as Dr. Nisar mentioned, we have been operating children of all ages. I'm using the word children because we're dealing with congenital anomalies. But yes, we have operated on patients 35, 40 years. But I think the way the society is changing now, so अभी तो in our department also, in our institute, we have made a rule that we are dealing with all cases up to 14 years fresh and up to 18 years if they are our follow-up. Now the point comes that there is a child of extrophy bladder. हमारे डिपार्टमेंट में बचपन में क्लोजर कर दिया, ब्लैडर ने रिकंस्ट्रक्शन कर दिया. By the time he is 18, he is facing the consequences of fall in renal function, suppose, and at the age of 20 years, suppose he needs an augmentation to reduce the pressures or to increase the volume. Ideally, it should have been done before 18, but नहीं हुआ, जरूरत नहीं पड़ी. So who should be doing it? So theoretically speaking, it sounds right that 20-year-old child, we deal with extrophy routinely, we should do it. And when we refer this child to urologists, they are very reluctant to take over that child because, it is a new unexplored domain for them. And surgery में तो वही होता है, भाई तुम्हारा केस है, तुम handle करो. But the way the medico-legal experts look at this, so what we are doing now is that it will be posted by the urologists in the urology OT. They will be the surgeons and we will go and together we will operate.
That's what I wanted to say, Prabhu sir. That's the point I wanted to say.
So कहीं ना कहीं सोसाइटी का जो डायरेक्शन हुआ है, द इन्वॉल्वमेंट ऑफ द लॉयर्स. अब होता क्या है कि व्हेन द मैटर कम्स टू द कोर्ट, इट इज हाउ द लॉयर्स परस्यू द केस. I see 2 or 3 cases going on in my department at the medical legal front. And if you listen to what happens in the court, things are eye-opening. We think on an entirely different level and they think with an entirely different perspective. So this is a never-ending debate, but yes.
Yeah, I think that's a good idea to have a team approach in these anomalies.
So हम लोग
Logistic is also a problem. I think if it's a big
Dr.
child, you
Amat
have
with
small
us
OTs.
also joining. Amat, can you have some comments? Amat?
Assalamu alaikum, sir. Good evening, everyone. So actually, we had a patient of Mullerian agenesis, and patient was married. That patient was done in LD hospital. So I
Okay.
think if the patient is from other department and we are being asked for help, so we should go and we should operate there only.
Good. Why not?
Ji, sir.
Thank you.
That is acceptable.
Thank you.
With this, Dr. Vijay.
So nicely. We have presented two cases nicely. I think it's a very joyful and happy moment for JnK chapter. We have conducted our first virtual class or case presentations. In future also we'll be doing. I really want to thank Dr. Prabodh Goyal and Dr. Munir for moderating the session, and I'm also thankful to senior members for attending this meeting and for honoring us by attending this. We had around 19 to 20 members in this first meeting. It's really a applauding moment for encouraging moment for us. So in future also we'll be having, and different institutions like this time SKIMS was there. Next time we'll request either GMC Srinagar or GMC Jammu, and in future we'll also be having few of the case discussions, or we can include a few of the external experts also from outside the state also for some guest lecture sort of things based related to research or other topics, other relevant topics for our present context. So with this, we can close the meeting. Really, once again, I want to thank everyone. And yes, a special thanks to IAPS, who has given us this Zoom link with unlimited hours. This Zoom link, and I'll try to record. It's already recorded. I'll try to convert it and we'll put in the group as early as it's available. Okay, so that in future we can have.
Vijay sir, can you take it for 2 minutes? Vijay sir.
Entire JnK chapter for this initiative, and I think it's a good beginning, so we'll carry it forward.
Thank you, Prabhu. Thank you.
Vijay sir, can I take for a minute?
Yes, please.
Sir Nisar sir, you there?
Ji.
Everyone is there. Please carry on.
So, sir, we have went ahead for the first conference, first JK chapter conference. I have sought all the permissions. So we'll be having the first conference JK chapter in GMC Jammu main auditorium. It will be on 25th and 26th of April.
I think we can have a separate discussion on this our WhatsApp group.
That's fine. That's fine.
It's just an announcement, sir. It's just an announcement from him.
It's just an announcement. We'll be coming with the first flyer very soon. That's it.
When do you want? When are you planning?
It's in April, sir. 25th and 26th
यार अप्रैल थोड़ी गर्मी होती है, थोड़ा कम करो यार उससे पहले.
Sir, permission we got for that only.
April is hot in Jammu, यार.
नहीं sir, it's fine. इतना बुरा नहीं होता है.
Then I thought if it is something somewhere in March or.
Sir, we will discuss about it. I'll let you know.
Well, okay. You come out with this program on WhatsApp group. We'll see.
Yeah, I'll discuss.